Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of our show. Today, bringing another really fascinating guest involved in science and technology and medicine, creating a better tomorrow for many people out there. Today on the show, we have the honor of being joined by Dr. Forrest Ringold of Surgical Association of Mobile, Alabama, who is a leading expert in both bariatric as well as robotic surgery and is renowned for his expertise in transforming lives through weight loss surgery, as well as other innovative abdominal treatments, and with a really broad understanding of both traditional laparoscopic techniques as well as some of these cutting-edge robotic technologies that we'll be getting into. Dr. Ringold specializes in a wide range of surgical procedures aimed at improving health and quality of life of patients, including things like a gastric bypass, sleeve gastrectomy, lap band, as well as some more advanced technologies that we'll be talking about, as well as pioneering advancements in reflux surgery and esophageal and stomach diseases. Dr. Ringold is also a leading authority in his field, and he serves as both a key opinion leader for both Intuitive Surgical and Teleflex Medical, two of the most respected names in medical devices in the sphere. And he has very innovative approaches to the latest in gastrointestinal surgery, pursuing various groundbreaking advancements. Also, he serves as a clinical instructor at the University of South Alabama's Department of Surgery, as well as president of Alabama State Chapter of the American Society for Metabolic and Bariatric Surgery. Did both his medical schooling and his residency, University of South Alabama Medical School and South Alabama Medical Center. A lot to get into today. I'm very honored to have him with us. Dr. Forrest Ringold, thank you so much for taking time to come on the show.
Oh, thank you so much for having me, Ira. Pleasure to be here and join you today.
Yeah, it's great having you. As mentioned before this show, we haven't gotten into a lot of these themes, so I'm really looking forward to the discussion. Before we get started, though, talking about all of these themes, would love to start off as we typically do by just handing things over to you for a few minutes to tell a little bit more about your background. If you could talk about why medicine, why surgery, and ultimately why gastroenterology and this very unique area of surgery. I took a look at some of your early papers back in the 90s on gastric feeding terms and things like that. So GI interested you at a very early stage of things. Take us back to the early days, if you would.
Yeah, absolutely. I really, truly have no idea why I originally wanted to go into the field of medicine. There's nobody in my family who really was involved in that field. But, from the earliest I can ever remember, I thought, I'm going to be a surgeon and that's what I'm going to do with my life. And so that's ultimately what I did. I just kind of had a focus my entire life that's what I was going to do. And I'll tell you, Ira, I knew nothing at all about the field of bariatric medicine or the study of weight loss. But in my surgical training, as it turns out, at the University of South Alabama, my vice chairman was a bariatric surgeon or weight loss surgeon. And so I really, early in my career, got some hands-on experience. And, back in the day when I was doing this, it just wasn't as maybe readily accepted as it is in 2025. And so it was quite foreign to me. But what I came to realize very, very early was that we were really making differences in these people's lives. I saw that the patients really needed help, and I saw that an amazing transition for them when I would follow up in the clinic with my vice chairman of surgery. And the other thing I noticed was that the patients absolutely loved him. And so, it's quite rewarding to be involved in that sort of situation. And so, when I was finishing my training, as it turns out, in 2002, probably the kind of hottest procedure out there across the country for a young surgeon was a laparoscopic or minimally invasive gastric bypass, or one of the weight loss procedures that we perform. And so, when I was in training, we did these procedures with a traditional large midline incision. And although these patients did extraordinarily well, they were in the hospital, really in the ICU for several days, and then transitioned to a floor bed for several days, and really had about 7 to 10 days hospitalization. And as I was coming out of my training, physicians started to transition this open or traditional incision technique to a laparoscopic technique where we just make really small incisions. And it was quite attractive to me, honestly, because the technical skill required to do this minimally invasive surgery for these patients was just enticing for me to do. But it also afforded these patients the ability to have a major surgery and get in and out of the hospital now in probably 1 to 2 days. So it really was a big ordeal clinically for the patients. Is quite a technical procedure for a young surgeon. And it really just kind of melded everything into one. And for me. And so that's really the way I wanted to dedicate my life. I joined a private practice here where I live in Mobile, Alabama. And I've been there ever since. I've been performing these surgeries ever since, and just trying to improve over the years and the safety and the effectiveness of these procedures.
Mm-hmm. Excellent. And, when I was reading your bio, I rattled off, some of the terms that folks may be more familiar with, like gastric bypass, like sleeve gastrectomy. Then there's other procedures, in your long dossier, which we'll get to a little later, things like magnetic anastomotic technology, which we'll talk about that later on. But so there's a lot going on, and I'd love, if we could sort of take a 2025 perspective on this space, because I think, obviously the last couple of years, right, have been all about GLP-1 drugs and weight loss associated with them. But, and when we look at sort of the comparisons, putting aside the surgery part of it for a second, I mean, your area of weight loss, significant weight loss compared to the GLP-1 drugs, very rapid results. You impact, as they say, sort of the health span perspective. It's not just obesity, but you impact diabetes and hypertension and everything else. Where are we in 2025 in sort of just the bariatric weight loss segment, let's say, and how has all things GLP-1 impacted what you do? Because it seems like you do a lot more. Let's put it that way, because I've talked to GLP-1 folks. I know about that stuff, but reintroduce us and educate us on bariatric weight loss, because it's dramatic.
Yeah, absolutely. Great question. And I could talk to you, Ira, for quite a long time about this, because obviously this is my passion. But I'm good just to give it to you kind of as a bird's eye view of the state of bariatric medicine in 2025. The two workhorse procedures that are performed across the country, I would say, are sleeve gastrectomy and gastric bypass. With sleeve gastrectomy being the most commonly performed, We do about, as a nation of surgeons, 140,000 of those procedures a year. And I think, people really like that procedure because of its safety. Um, it's extraordinarily safe, but they also like it because of its effectiveness. And so the average person that undergoes a sleeve gastrectomy for weight loss will lose about 60% of their excess weight. And so, if you happen to be 100 pounds overweight, you would expect to lose about 60 of those pounds. Um, and it's easy for people to understand that procedure. We basically take a basketball volume stomach, and using a special stapling device, we reduce that volume down to the volume of a banana. So people really can grasp that concept, and they understand if they have a smaller stomach, then they feel satisfied with a smaller portion of food. And if they eat smaller portions long term, then they are able to lose that 60% of their excess weight. Perhaps the what I would call the gold standard procedure is the gastric bypass, and that's the other workhorse procedure. And we do about, as a nation of surgeons, I would say 40,000 a year. It's the grandfather of all procedures, and it's what everything else is compared to, even in 2025. And I tell my patients that they can expect to lose about 75% of their excess weight with that procedure. And it's configured a little bit differently, Ira, in that instead of creating that banana shaped tube, we actually will create a small, like 2-ounce stomach pouch where all the food goes to. And then we bring up a piece of intestine and sew it to the outlet of the stomach, such that all of the food that is consumed, it'll go into that small pouch, and it will bypass the majority of the stomach. And that's why we call it a bypass, a gastric bypass, meaning stomach bypass.
Mm-hmm.
So there is some anastomotic surgically created connections with this procedure. It's extraordinarily safe, but theoretically carries a slightly higher risk. And then, there's other procedures that I perform, duodenal switch, SADI, that are for individuals who have a extremely high BMI. That involve bypassing a portion of the small intestine where food is absorbed. And those are less common. We do about 4,000 of those a year. But they're all safe. I do them all robotically, as you mentioned earlier, and all very effective procedures.
Mm-hmm. Continuing along that, and then we'll get into the recent paper and the Teleflex technologies and all that. But you just mentioned robotics, and clearly you've had to obviously train as a clinician, train as a surgeon, but now you're also a robotic engineer in essence. And again, I've looked at some of your papers in this area as well. Talk a little bit about I'll just call it the roboticization, let's say, of this space, because it's one where, I guess we see robotics everywhere nowadays, in all sort of specialties, but in your area, it kind of took off early on. What's that been like for you in terms of, hey, you gotta, I don't just have to develop these new procedures, but I have to adapt them, and I got to learn to use this robot and all this other stuff. What's that been like? If you could take us, Forrest, into that realm as well.
Yeah, it's a great question, and sometimes I will have young physicians shadow me, or young students that are interested in the field of medicine. And I always tell them that being a physician is a lifelong learning process, and I always tell them that you can never master the field of medicine, certainly never master the field of surgery. Because again, technology progresses always, and so to your question, robotic surgery was non-existent when I was in my training. We were just starting to do laparoscopic gastric bypass, but I had to learn this technology over time during my practice. And of course, there was a lot of different training modules and training facilities that I went to learn the technology. But it was quite an advancement, I must say, over traditional laparoscopy. And if you think about performing surgery, Ira, with long, straight instruments that are do not articulate, they're really small instruments, and they allow you to make small incisions on a person's skin. So they're really good, but they don't really articulate like the human wrist. And so that's where robotics comes into play. The engineering involved with the robot is really kind of having a computer between the surgeon and the patient and allowing for a very, very small instrument to traverse a small incision in the skin, go into the abdominal cavity, and then allow the surgeon to be able to articulate the instrument just like the human hand, just like the human wrist. And that's the beauty of robotic surgery that we're able to operate with now. And it's not only that, but if you ever look at a surgical robot, you'll see that it has four different independent arms that can be controlled by the surgeon and at any given time. So I'm able to use my hands, I'm able to use my feet, all in concert so that I can manipulate all four of these instruments. And I guess I might say the other thing that's really beautiful about robotic surgery is the optics. So you combine really wonderful optics. And so for each of my two eyes, there is an independent camera that I look into. And so it's two high definition cameras, one for each eye, and the optics are 10 times magnified such that I am looking at a 3D view of a patient's anatomy. So if you combine all of that, then what you might understand is that the surgeon is able to perform an extraordinarily precise operation. They can do it with very small incisions, and they can do very, very advanced technique with those small incisions. And overall, in my opinion, it allows a patient to have less tissue trauma, therefore maybe less pain, therefore maybe a little quicker recovery. And overall, I just think they do better. And so we've taken the robotic approach and combined it with the weight loss surgical techniques. And that's where we are in 2025.
Very cool. Very cool. And a lot of these themes now come together in a very important paper that was just published in Obesity Surgery, basically focusing on, I guess, the last 8 or 9 years of your work, 250 plus patients that underwent various robotic assisted gastrectomies that you were talking about, and incorporating unique stapling technology. And I, as mentioned, you are a thought leader per Teleflex, and analyzed in this particular paper, and again the last almost a decade of your work, looking at how some of these technologies improve in what is known as or reduce post-operative gastroesophageal reflux disease, or de novo GERD following surgery. And obviously this is I guess maybe just one of the major issues that bypasses come with. And this is a very elegant set of solutions that, hey, if we can, as you were mentioning, take that basketball, shrink it down to a banana, and then also get rid of all the post-op nausea, vomiting, and GERD that comes with it, you're making patients' lives a lot better. So take a little time, if you would, for us to walk through this period of your work, and then obviously the new study, and what is SGS stapling is compared to multi-virus stapling, and educate us on that as well.
Yeah, well, thank you for the question, Ira. And you had asked me about GLP-1s a little bit earlier, and I apologize I didn't touch on that. But I might say that in the area of GLP-1s, which we love as surgeons. Any tool that we have to help people lose weight, we want to utilize that technology and help those patients. But GLP-1s are great. They have they do have a complication profile for some patients, but it's very minimal. But I think, especially in 2025, as we use these GLP-1s, we want to have the absolute safest surgical techniques with the absolute most minimal potential side effects so that these procedures will work well alongside the GLP-1s. And so when you look at a sleeve gastrectomy, it is an extraordinarily safe procedure. I mentioned earlier we'd go from the basketball-sized stomach down to a banana, and the safety of it is incredible. 1 in 1,000 death risk. There's 3 in 1,000 leak risk. So it's extraordinarily a great operation, and these patients typically lose 60% of their excess body weight. I would say if there was an Achilles heel to the procedure, it would be postoperative reflux. Most people do not have that, but there's a substantial percentage of people, I'd say about 20% of people will have some element of reflux. And so I've spent my entire career of performing sleeve gastrectomy trying to improve upon that potential outcome for patients. And so I'll have some patients who will come back and see me long term and they'll say, yeah, doing great, no problems whatsoever, everything's wonderful. That'll be most of the patients. And I'll have an occasional patient come in and say, I've got a little reflux, it's not that bad, I don't really have to take anything for it. And then I'll have a patient occasionally that'll come in and say, well, it's bad, but I take a medicine for it. And, it's not a problem. And then very rarely I'll have a patient come in that says, it's so bad, we have to do something. We have to alter something. And so for those last two categories of patients, I've really tried to reduce the incidence of that. And that's where this paper you were referring to comes into play. So, for years and years, I personally felt that this reflux was occurring because we, as surgeons, maybe were not being aggressive enough and not repairing a subtle hiatal hernia at the time of the sleeve gastrectomy. And so for many years, I was pretty aggressive and I would repair these hiatal hernias alongside the sleeve gastrectomy. But unfortunately, when I would look at my data, the data was very similar, as if I hadn't fixed the hiatal hernia. So I began to think that maybe a slight detail of this creating the sleeve gastrectomy is that we would use a series of staples that are about 60 millimeters in length, usually between 4 and 6 cartridges to create the long sleeve gastrectomy. And I began to think that perhaps using these 4 to 6 cartridges and creating that long staple line, perhaps there was some hourglassing, if you will, of the tube, which would allow a little bit for stasis inside the sleeve and would allow for delayed clearance of the intraluminal contents and perhaps allow these patients to have reflux because of the retained fluid within that sleeve gastrectomy. And so about that time, Teleflex came out with a single-use, single-fire stapler that is 23 centimeters, so quite a bit longer than the standard stapler that we used previously. And that one stapler allows you to go from point A to point Z with one single firing. And when you do that, you can measure twice and cut once, and just like a carpenter, and you can look at your sleeve and make sure you're extraordinarily happy with it before you ever make any single cut. And that allows for the sleeve, the final product, to have less hourglassing, less twist, less kink. And so that was my hypothesis, that maybe if I use this, then we could cut down on the reflux rate after the surgery. And so I started using it with that hypothesis in mind. And I didn't really tell anybody about that subtle change in technique, especially my nurse practitioner. My nurse practitioner, she does not go into the operating room with me, but she sees my patients for follow-up in the office. And so after I'd been using it for a little while, she came up to me and asked me, she said, Dr. Ringold, have you done something different with your sleeve gastrectomies? And I just kind of chuckled and I said, well, yeah, I've changed something. Why are you asking me? And she said, well, your patients are doing a lot better. They immediately post-op, they're not having any nausea, and I'm not having to prescribe any antacid medication for them anymore. And I said, well, that's interesting. Let's go back and look at the data. And so we did. We went back and looked at our own personal data, and that was the impetus. That was the entire impetus to do this study. And so when we looked at the data, we did see that there was a substantial difference by changing only that one thing. And so it's been quite cool, honestly, to see this. And so we pulled the data. We looked at it. We looked at it in all kinds of different ways, and that's really what our publication was about. The other variables were all the same. The post-op weight loss was the same. The complication profile was very similar, but the big change was reflux. And so, for instance, not to bore you with statistics, but it's quite significant. So, like people that would develop reflux that never had reflux before sleeve, it's called de novo reflux. 10.9% of my patients after the multi-fire stapling group had a sleeve, 10.9% of them had reflux that needed to be treated. And in the new 23 centimeter stapler group, it was 1.8%. So that was just a dramatic change. And it was similar among other cohorts that we looked at. So like the overall rate of reflux in the new stapler was 7%. And that was compared to the multi-fire stapler, which was 26%. So, it was just quite a change. And so I'm very proud of this finding. And as it turns out, I think we're going to see more studies from other surgeons that are coming out that are going to reinforce this. And so I think it's going to be a really nice improvement for our patients across the country in years to come.
Excellent. And just I haven't know. Obviously, you're known for your specialization in bariatric surgery, but again, at surgical associations of Mobile, you are also involved in reflux surgery, abdominal diseases, and so forth. Are there just applications for this type of technology in more broadly and just reflux? Again, I was looking, I had to research some of these procedures like fundoplication, which is kind of interesting in its own right, the LINX reflux management system and all that. Other applications, obviously, you found this amazing, aspect of it per your work the last 10 years in bariatrics, but what are other applications of a stapler like this that you could just educate us on?
Yeah, Ira, this particular device is specifically for one procedure and one procedure only. So, sleeve gastrectomy, that's its claim to fame. But you might think, well, maybe that's kind of really a narrow indication. But as you may recall, I mentioned to you, 140,000 sleeves are being done a year. And so if you take 25% of those patients, and they all are being treated with PPIs or anti-reflux medications, we can make a substantial improvement across the country.
Yep. First, what other? I mean, again, I mentioned, you're always on the cutting edge, not just with the stapling technology, but looking at a lot of these other procedures. That you mentioned one, this magnetic anasto anastomotic technology, where basically it seems like in this case you're getting rid of staples overall and using magnets, which itself is kind of wild. I watched it in a presentation on this intergastric balloon technology. What else is
Yeah.
happening in this space that's looking out 2026, 2030, wherever we're headed? What
Yeah.
are the technologies that you're excited about in bariatrics that may be groundbreaking and transformational in the coming years?
Yeah. Well, thank you for the question. I am extraordinarily excited about a new technology that is just coming into play, uh, involving magnets, believe it or not. And just to give you a little background about what we do in 2025 and what we've done in years past. So, when I was talking to you about gastric bypass, and I was kind of giving you a bird's eye view of the way the procedure is performed, where we will take a piece of intestine and we'll physically connect it to the new small stomach. And the way in which we do that, I personally will just take a suture and I will suture in two layers the connection, make a small incision in the intestine, small incision in the stomach, and then I'll close it with a suture. Other surgeons might take a stapling device and they may make a hole in the intestine, a hole in the stomach, and they will staple the stapling device, which will not only staple, but it will cut a larger hole in the intestine. And then they will take a stitch and they'll close the small remaining hole. So that's how anastomoses, as we call them, are created in 2025, and that's what we've done in years past. And this is a great way to do surgery. The complication profile is very low, but there is always a small chance of leakage where we create that connection or anastomosis. And there is a small chance as well of hemorrhage or bleeding. And so we always want to improve upon that small incidence of leakage or bleeding. And um, that is where the magnetic compression anastomosis comes into play. And so um, this is really cool. And so what I am going to be using this technology for is revision of a sleeve gastrectomy in a patient who maybe wants to lose a little bit more weight. Um, and so what I will do is I'll bring up the small intestine and I'll connect it to the outlet of the sleeve. In 2025, again, I would sew that. And I would bypass a large percentage of the small intestine, which is the absorptive area of the food that is eaten. And so now with this magnetic compression technology, this is how it's going to go. All right, it's really cool. Um, a patient will come in the morning, and they will literally swallow one of the two magnets. We'll wait a period of time for the magnet to go down the esophagus into the stomach and go into the small intestine. It will continuously move through the GI tract. Then I take an X-ray, make sure it's where I want it to be, and then I take the patient to surgery and put them to sleep. And then I make a couple small incisions on the skin, and then I find the magnet in the intestine, and then I do the measurements that I need to do to allow the patient to bypass a percentage of their bowels so that they can lose additional weight. And then I'll take a special flexible telescope and go down through the mouth into the stomach with the second magnet. And then I will bring both magnets together, one with my scope in the mouth and the other magnet in the intestine that the patient swallowed. And then I'll just put them together and they will snap together into place. And that's it. And so what happens is that over the next 14 days or so, the tissue between the two magnets will compress, will become thinner and thinner and thinner, and ultimately there will be a hole created, or an anastomosis. All the while, the tissue on the outside is healing naturally, the body's natural healing process. And and then the other cool thing about this is once it happens, then both magnets together move right on through the intestinal tract as normal, and then it's expelled. And the GI tract is never violated. So, you know what I mean? So I don't have to cut a hole in the intestine. And so the premise behind all of this is that perhaps we can make a surgical connection with a extraordinarily low, or might I even say 0% incidence of leak or bleed. And so I think that this technology, even though I personally am going to use it for sleeve revision, I think it's going to have application across all fields of surgery in the years to come. And it's a really cool thing to keep your eye on. And I'm really, really excited about it.
It's really cool. Again, it's not just cool. It sounds fun. Not that, you know.
Absolutely.
But no, I very much enjoy, thinking about how we're sort of, I guess the term is bioconvergence that we use nowadays, but how we're, connecting physics in the sense of here magnetism in these procedures now, as opposed to, something more they could impact the tissue, as you're saying. And yeah, it's very impressive. And, again, I like to hear these stories about, folks like you that are always thinking about, what's next, and thinking about innovation in this context. What should we be on the lookout for in terms of you? I mean, I know that I think just maybe last week or a couple of weeks ago, the American Society for Metabolic and Bariatric Surgery conference took place. Your stapling platform paper and topic was presented, I think, in their annual paper, or sort of set of papers for that meeting. Other things coming up in terms of conferences, other talks, anything that I missed while we have you today that's on the calendar for the next part of 2025, please.
Yeah. Again, thank you for the question. Yeah, we just, as a nation of surgeons, it's pretty cool. People might be interested to know. We get together once a year, and as a field of bariatric or weight loss surgeons, we get together and we discuss our techniques, our surgical pearls, if you will, some of our challenges, all in an effort to improve upon what we're doing and for the benefit of our patients. And so that was a great meeting, and we were able to share some of our advancements that we've talked about with post-sleeve reflux, and hopefully that will take off and progress across the nation. In regard to some of the events upcoming for me personally, so we have a state chapter meeting, and that's upcoming, and so all of the surgeons within our state will do the same thing. We will get together and we'll talk about our challenges and our successes and things that we can do to improve upon patient care. So that's coming up in August. And we always like to talk about access to care. And what I'm talking about there is, we believe that we have life-changing treatments for our patients. And we do about 200,000 procedures yearly as a nation for 22 million people that could use the procedure. So, I mean, there's just a tremendous amount of people who are not able, for various reasons, to have life-altering and sometimes life-saving procedures. And so that's very frustrating if you're a physician and you're trying to help people, that you have a technology, you have a technique where you can help people and you just can't give it to them. So we're really trying to talk to our state legislature. We're trying to talk to our insurance companies and trying to remove barriers to healthcare. Of course, the procedures are expensive and somebody has to pay for them. And that's a different discussion for another day. But still, we look at obesity as a chronic disease as physicians, and we are trying to get all of our nation and the world to see it the way that we see it. We don't want people with obesity to be feel like that this is a negative stigma. We want people to understand, this is an illness that may need a lifelong a lifetime of therapy, may need GLP-1s, may ultimately need surgery, may need both. But it's kind of like diabetes, if you have a treatment for it, you sure would like to get the treatment to make the patient better. And so that's what we're trying to do. We're trying to increase our access to care. And so that's what we have upcoming this August, and looking forward to that as well.
Yeah, it's yeah, again, I like the way you look at that from the perspective, because it really is a mother, one of the mothers of all diseases, in the sense that obesity does trickle down to many other things that impact your health span. So yeah, it's a great mission. It's very impressive work, and I look forward to continue to follow you, the organization, the rest of the practice, and keep an eye on many of these very innovative therapies that you're championing. But again, for everybody that is going to be listening to this episode of our show across the various podcast networks, or who will be watching on the YouTube channel. Again, you've been spending time with Dr. Forrest Ringold, Surgical Association of Mobile, doing really amazing things to, as they say, transform lives through weight loss surgery and innovative abdominal treatments. Forrest, I want to thank you for taking the time out of your schedule to talk to us for a little while today about everything you're up to and educating us on these unique procedures. Obviously, thank you for everything you do. And as we like to say on our show, thanks for helping to create a better tomorrow for millions of people out there via the type of technology and medicine that you're championing here. It's really an awesome story, and I look forward to continue to follow it.
Well, thank you so much for having me, and I appreciate your interest, and just enjoyed it. Thanks so much.
Really great having you.